Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hi, everyone. Welcome to Cracking Cancer. I'm your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and I am joined today by Samantha Murrell.
Hey everyone, Samantha Murrell. I'm a patient advocate. I have non-small cell lung cancer with a HER2 mutation. I am happy to be here. Thanks for having me, Kyle.
Thanks for joining. And today we're going over a topic, what is a medical oncologist? So this is something, 20 some odd, 30 weeks into starting this episode, or starting this podcast series, we figured maybe we should go into what I actually do. Why are you here? Why are you doing this? This is jumping off a previous episode, which was What is a Radiologist with Lauren Groner, who I really enjoyed that episode, and people got a lot out of it. And we figured, why don't we lay a little more foundation out and let people better know who is involved with the care teams, when do you see who does what, through the medical oncologist perspective. So hopefully you'll find this helpful. And Samantha, maybe you can kick us off with whatever questions you're starting with.
Yeah, you better be good at answering these. So
I've had some experience, or people will find out I'm a total sham, and yeah,
no pressure. So let's start with the basics about the role of a medical oncologist and how it's potentially different from surgical or radiation oncologists.
Yeah, and those are the three primary oncology providers, I would say. There are many, many more, but when people get together and they come up with a care plan, it's usually surgical oncology, radiation oncology, and medical oncology that are getting together and talking about it. And the roles are different. The medical oncologist role, broadly speaking, is to give therapies that go everywhere in the body. That's what we do. We give things that are infusions, pills, and then we monitor the rest of the organs for side effects and make sure that the person is doing well, largely throughout the whole continuum of their care. Surgical oncologists, as they sound, they do surgeries. They may or may not be involved with patients' care after the surgery. And the same is true for radiation oncologists. They administer radiation, and they may or may not be there for the duration of someone's care. Usually how these are integrated is a surgical oncologist will operate palliatively, meaning it alleviates symptoms, or curatively, meaning the surgeon is doing something with the intent to cure someone. And the radiation oncologist, similar. If someone's having symptoms, you can get radiation. The radiation oncologist will do the dosing. They'll figure out how to avoid targeting healthy tissues with the radiation. And that may alleviate the pain associated with that. Bone metastases are a good example there. Or they may be involved with a curative intention strategy. And a lot of times these are paired together. The surgeon may operate, they may radiate the areas that were not totally gotten from the surgery, and then the medical oncologist may give something afterwards. So we all work together, but it's not necessarily a guarantee that a given patient would see all of the oncology providers. And that's true for people may not see a medical oncologist, and people may not see a surgical oncologist, depending on their tumor type and their circumstance. So we all work together, but we have pretty different roles.
So how is your training different in terms of like your medical school trajectory?
Yeah, so it starts with, everyone has to go through some sort of undergraduate, at least in the United States system. And then we all go through medical school. Medical school is 4 years, and we all go through the same one. Well, maybe not the same exact medical school, but we all go through the same medical school process usually. And from there, you get your year and a half to 2 years, 1 year, something around that, depending on the med school, which is pretty much coursework. That's what people think of, I think, when they think med school is like sitting in classes and taking notes, doing dissection on human cadavers or models that kind of emulate that. And then after that first year, we are 1 to 2 years, then we all enter clinics. And the clinical rotations that we all go through are the same, by and large. There are mandatory ones. Surgery is one. Internal medicine, what I am a subfield of, is another. And then after you go through all that, then you do electives. Radiation oncology actually is not usually one that's mandatory. So if someone's interested in that, they might have to intentionally say, I would like to go do a radiation oncology elective. And then they'd have the opportunity to do that. I did that, as I did surgical oncology. And, and then you get a flavor of what you'd like to do, and then you apply to residency. And that's where that first differentiation point comes in between the surgical oncologist, the radiation oncologist, and the medical oncologist. Surgical oncologists, depending on the field they're in and the type of area they're operating on, can go directly to becoming the type of surgeon they want to do, or they might do general surgery first, but they get specialized surgical training one way or another. And a surgical oncologist, it depends more on the anatomic location than if they're doing cancer or not. For example, a neurosurgeon will be treating brain tumors, not someone who was a general surgeon that was doing pancreatic cancer. So that's another nuance there, but it's all, they did surgical training. That's what they're there for. Radiation oncology is its own thing. They'll do an intern year. They'll do 1 year of maybe medicine or surgical general training, and then they'll go into radiation oncology frequently. And a lot of times those are kind of combined programs. So they're started off just doing radiation oncology. And then for medical oncology, we're a subspecialty of internal medicine. So the primary care doctor that many adults will go see is an internist. And sometimes the people you'll see taking care of you in the hospital are internists. And then that person, that field, can get further training. And that's what I did as a medical oncologist. And usually that's in the form of about 3 years of additional oncology training on top of 3 years of internal medicine. So the training pathways are very different. The surgeons are trained to operate. They're not trained for long-term care of an individual's organs. The radiation oncologist is trained to deliver different forms of radiation to different tumor types, to different areas of the body, design treatment plans around what can be tolerated and what can't be tolerated by certain organs. And then the medical oncologist is trained to help the full individual be healthy throughout a treatment course, really. And that can be psychosocially, but I would say more commonly, it's adverse reactions for liver toxicity, things like that. So we're good at that kind of stuff. And more often than not, if someone's seeing all three, it's usually the medical oncologist that will see them throughout the treatment course, because that's the treatment they're mostly getting throughout a long treatment course. It's pretty uncommon for someone to get radiation indefinitely, but they will get chemotherapy or targeted therapy or something else indefinitely. So we tend to be the more long-term person, I would say, in an individual's treatment course. Does that sound like your experience with the oncology team, Samantha?
Yes, absolutely. I think my biggest misconception, though, was that the medical oncologist was kind of the gatekeeper to the surgical and the radiation. And that's not necessarily the case. Like, they can all work cohesively together. They do talk often, right? About if you're meeting with one, they tend to converse and talk with each other about the case. I definitely had a misconception that they were very separate, and the medical oncologist had to refer you to go see these other expertise, when that's not necessarily the case.
Certainly not. Yeah. I think there are different areas of oncology care where the surgical oncologist, the radiation oncologist, or the medical oncologist will really be the quarterback. Mm-hmm. They'll be the champion of that section. And an example might be for a prostate cancer. The many prostate cancers can be managed surgically or with radiation, and they won't need to see a medical oncologist. So the flow of their care would not be seeing me and then me saying, oh, you need surgery. It might be the primary care provider saying, they have this, they do the staging, and oh, there's a little localized thing, low risk. Why don't you go talk to a surgeon and see if you want to do something about it? But it may not necessarily be through us. The same is true with many other cancers. And here we're talking about solid tumors. It's different with the liquid tumors. Those are usually managed by medical oncologists, meaning leukemia, lymphoma. But for solid tumors, if something's really small, it may just be a surgery or a dose of radiation or a treatment course of radiation, and that's it. And you don't really have a role to seeing the medical oncologist because we wouldn't really provide a whole lot. We don't want to give therapies that only cause harm without any potential benefit. Although I've known many circumstances where that occurs and people feel uncomfortable not seeing one or the other providers. The same is true the other way around. If someone has disease that's spread throughout the body, many times we won't necessarily recommend them to go see a surgeon because the surgeon can't operate in 10 different areas. So not all groups are involved in everyone's care, and that can be really confusing sometimes.
It's very confusing.
Yeah. Well, and I'll say the areas where people will work together to form a treatment plan that consists of all these things, and when the treatment plan won't consist of all these things, is not always cut and dry. Like, cancer is really complicated. Sometimes you may do radiation in circumstances that another team somewhere else might not do radiation, and in one tumor type may be different from another tumor type. So it is a really muddy situation, and I think the first step is knowing who the general deliverers of care are, and when might you and might you not expect to see them all.
And I know this podcast is about medical oncology specifically, but aren't we missing someone in that circle too, like interventional radiologists? Would they also be part of that circle? Or not necessarily.
I probably, I'm going to upset some interventional radiation oncologists here. I probably wouldn't put them in that primary bucket, and I don't think they would either.
Okay.
So when I lump these groups together, the reason I'm lumping them together as the primary deliverers of care is because these are the three primary treatment modalities that we use: surgery, radiation, and medical oncology tools. Interventional radiology does happen sometimes, but they're not usually at the table determining someone's treatment plan because it's so rare that we'll use an interventional radiology strategy. It happens. It's common with liver cancers. There are some tumor boards that might even include them. Some types of cancer might have them sit at the table with them. But more often than not, it's a case-by-case basis as to whether or not an interventional radiology strategy would be useful. And most of the time, they're not specifically cancer specialists.
Okay, interesting.
They will use interventional radiology tools to accomplish a grouping of things. They have many skill sets, but it's rare that that's just cancer, to my knowledge.
Okay, that's good to know. Thank you for clarifying that. Yeah,
there may be certain hospitals, major centers that see only cancer patients where the interventional radiologist really will be a cancer specialist. But that's not usually the case. They can do a bunch of stuff.
So I'm going to switch to working with patients. So we did a podcast ages ago where I think we talked about like how my experience was with my first meeting of my oncologist and what that looked like. I'd love to kind of switch that back onto you in terms of like what does an appointment from your perspective, a successful first appointment look like when you're first meeting with a patient?
Yeah, that's a good question. I think for me, I have a lot of pressure on myself when I'm first meeting a patient because it's not lost on me that people are coming to a new medical oncologist, whether it's their first diagnosis or for a second opinion. And there's a lot riding on that meeting. There's a lot of hope there. There's a lot of information that needs to be transmitted one way or another. And some of that is the accurate medical information that's pertinent to that patient that is appropriate to give. Not everything is perfectly appropriate to give at every meeting. But then there's also the subjective cues to say, I want that person to be comfortable around me. I want to make sure that if there's problems, they know they can approach me. So there's also body language cues that you have to convey and make that person feel safe, heard, and to build trust. So it's tough. So I have a lot of pressure on myself starting those visits And I am not someone who walks in with a general understanding of what's going on and can come up with a treatment plan. I have to do a lot of preparation.
Mm-hmm.
So I've read a lot about a new patient's chart. It's a rare exception that I didn't get something ahead of time, but I feel like someone has put a lot of trust. Usually they're traveling. So there's a lot of pressure to deliver that and to make that worth it for them. Because they can go anywhere and they chose to see me. So for me, I think there's this pressure and anxiety would be the first initial symptoms I have. But what makes it successful is quickly understanding what their goals are and figuring out a way together to make sure that we can meet those goals. And it's tough because we have the knowledge of the academic literature. So I can have a good sense of what's the next treatment course that I think would prolong life the most, and based on scientific studies. But that may not be consistent with what someone wants.
Right.
So then you have to have the knowledge of what are options B, C, D, and E that might best fit their goals. And thinking of that on the fly is not super easy for me, particularly when there's trials. And like you can go somewhere else and get a trial, and there's a different trial than maybe the one that we can provide. And knowing what's best for the patient is really hard to do. But that's the goal. And it's a tough goal to deliver on. But that's why we do this field or why we go into this field is to provide, the longest amount of time at the highest quality of life for someone. And navigating that isn't easy, and it's a really high bar.
Yeah, I'm curious on this. Do you get excited or intrigued when you have a patient that brings a lot of literature to you and or trials or things like that?
Yeah, I'll say when people bring their own literature and have done their own homework, having trained at Anderson, I'm pretty used to it. There's a large contingency of patients that will seek second opinions there, and they are really informed about their cancer biology. So I would say I'm used to it, and it doesn't bother me or anything. But I will say it's vulnerable as a provider when a patient does that, because they're going to come in most likely with some information that you may not have read, or at least you didn't understand it to the depth that there's the study right in front of you and they can quote exact statistic that you don't have at the top of your mind. And it's vulnerable it's almost like a PhD dissertation, where not that I have a PhD, but I imagine that, people are asking you very nuanced questions about something that you're expected to know the answers to. And that can be really vulnerable as a provider. So I think it's a two-way street. If a patient is someone that has the aptitude and the interest to get that deep into their cancer biology, I think it does probably drive better care, or at least it has the potential to. And bringing that to your oncologist, no matter how specialized they are, they may not have come across that. And to have the grace to say, we're all just human, we're all just trying our best, to not be necessarily disappointed if the person doesn't have that memorized. So to me, it's a little anxiety provoking in that I may showcase my own inadequacies, or at least that's how I perceive them, because I'd like to be the master of everything, at least within my field. But so much is coming out that it's really hard to keep up with absolutely everything.
Yeah.
But to the patient who does that, bring it on. It's great. Keep doing it. Bring it in and acknowledge you're part of a team now. You as the patient are part of a team, and your care team is that team. You're part of it. And, you're the one really driving your own care nowadays. So I think, to me, I embrace it with the caveats that it's not always super comfortable.
So how does it work because you touched on second opinions a little bit, how does it work when you're a second opinion and in terms of your interaction with the other doctor that's the primary medical oncologist for that patient? What does that look like?
So medical oncologists work together all the time. And it's interesting because it's probably different in surgical oncology or radiation oncology because you're not going to get two surgeries. You're not going
Mhm.
to, or at least, not the same surgery twice probably. Whereas you can kind of split your care with medical oncology across a few different places. And the relationship with a medical oncologist is usually very, very positive, particularly now. I mean, people are more mobile than they were, I'm sure, ever before. So the circumstance in which someone gets a second opinion or wants to transfer care is really common.
Mhm.
It's pretty standard. It's pretty normal. I'll say when people get second opinions, if you're curious about something as a provider, if I'm like, they were offering a therapy, I wouldn't really have done that. I think a lot of times we'll just talk to each other.
Mhm.
And it's easy to play Monday morning quarterback from someone else's care plan if you have more information, or if you're lacking vital information that they had. It's really easy to say, oh, that's crazy. And then you talk to them and you, oh, okay, well, I guess that wasn't that crazy, knowing,
Mhm.
knowing these details. So I think by and large, medical oncologists work together really, really well. It's more often than not, when barriers are in place, it's institutional barriers. Like it's hard to get scans. It's hard to get information from one institution to the other.
Mhm.
Pathology
Mhm.
slides don't get transferred in a timely fashion. So care can break down because of logistical barriers, but it's not usually at the individual level.
That's good to know because I think there's a big misconception that you will really annoy or irritate your primary medical oncologist if you get a second opinion.
It's funny. I had Dr. Ben Fangman, one of my co fellows. We had to talk about community versus
Mhm.
academic oncology, and I share his perspective that if your oncologist is upset that you got a second opinion about your own cancer care, then maybe you should consider a different oncologist.
Right.
Um, like this is your life. There's no. I don't have to deal with the consequences of my prescriptions. Isn't that
Mhm.
crazy? Like I make recommendations and I don't have to deal with the side effects.
Right. Right.
So, and it's very easy for us as medical oncology providers to look at the best data. And when I say best data, I mean strongest quality of data that shows maybe the best outcomes and
Mhm.
say, oh, you should do that.
Mhm.
And when you have a full clinic of a lot of people and you're making a lot of these decisions, you may not have the time as a medical oncologist to really consider those options B, C, D, and E and the unique considerations for that patient. So I think it's really imperative on the person who is coming through to ask, the nuanced questions that are at least relevant to their life. I'll give you a great example. I was seeing a patient the other day who was coming for a second opinion, and they were coming specifically for a trial that we had.
Mhm.
And they didn't appreciate that the trial would require them to be here every 2 weeks,
Mhm.
and they don't live like right in the area. Like that's a big time commitment for
Mhm.
someone. Imagine if you had to travel every 2 weeks to a different area, and that just wasn't on your radar. You had no idea to expect that. So those kinds of considerations happen all the time, and it's very easy for me to say, "Oh, you're here on this trial. Okay, great. You feel okay? Look okay. Heart sounds good," and then we just continue. But it's important for the patient to bring those stuff up because it may not be the thing we recommend may not be the best and only option.
Mhm.
The psychosocial stuff really matters in medical oncology because you can attest to this. You're on a therapy for a while. And if you're just doing it because the medical oncologist says it and you don't want to upset them with a second opinion, you can be down a path that's not the best path for you.
Mhm. Absolutely. And I will say that people need to feel comfortable on firing their medical oncologist too if they feel it appropriate and it's okay to do.
Yeah, and that happens.
Yeah.
It's not I mean, I won't say it's like super common, but I'll say that it will not be the right fit for a good amount of people. It's common enough that if someone were to tell me that I wasn't the right fit for them, I wouldn't take it too. If 10 people did, maybe I'd start to say, "What am I doing wrong?"
maybe
But
maybe then you need to do some introspective
yeah,
yeah.
something's going on. Sometimes personalities just clash.
Mhm.
Um, Sometimes you want to work with someone who's a specialist in your disease, and you can be doing the same thing, but it's just a certain level of comfort
Mhm.
around someone who may uniquely study what you have. even if the trials are different, or even if the trials are the same, or the standard of care options are the same. And a lot of times what people will end up doing is they'll see a different medical oncologist because a unique opportunity arises.
Mm-hmm.
An example might be uh, a trial that isn't available in your location. You like your oncologist just fine, but they just don't have this trial. I
Right.
mean, actually, another example, I had a patient who I was going to see for a trial that we were going to enroll in, and the trial isn't open yet. So I called the patient and I had to say, hey, we don't have this trial open yet. It's probably best you don't come here.
Right.
Like it's not in your best interest to travel to see me just for me to tell you we don't have that trial available. Let me give you something else. And I think that gets into maybe another conception that people have where we're just interested in increased accruing and getting more patients in and billing. And, it's no secret, no margin, no mission. The hospital does have to bill, but we care about the patient far more. I'd much rather someone leave here. And I even emailed a different provider to say, hey, you have this trial. Are you able to see this patient soon? I'm worried about delays. And they're getting seen at a different institution that I facilitated. I don't bill
Mm-hmm.
for that.
Mm-hmm.
So we care about that. And if it's the right circumstance, a medical oncologist will send a patient to a different medical oncologist to try to get what they think is the best care for the patient. And I think that circumstance is common.
Mm-hmm. That's good. That's reassuring.
Yeah, I mean, that's kind of how it should be. And I think one of the challenges and one of the frustrations that people have when they're seeing medical oncology sometimes is a trial may be available somewhere and their medical oncologist didn't talk about it.
Mm-hmm.
And I'll say the trial landscape is vast and it's always changing. So it's hard for us to keep up with what institution has what trial and what disease type and, what nuances, what stage. There's just a lot going on. So
Mm-hmm.
if a medical oncologist doesn't talk about an opportunity that another institution has, it's not because they're trying to withhold that intentionally. It's probably just things are moving so quickly. It's really hard to keep up and they may not know about it. Another reason to be open and transparent with your medical oncologist about other things you might want to do, whether it's supplements, whether it's alternative therapies, whether it's trials at different institutions. You should be able to have that dialogue because you may know things that your oncologist doesn't know.
You brought up a hot topic that I think we should talk about. So you kind of set yourself up there. I'm presuming more and more common now is for people to go to their oncologist and talk to them about alternative therapies, vitamins, etc. And so I'm curious what your perspective or just what you're getting from the general field is. Is it frustration? Is it annoyance? Is it openness? Like I'm curious from your perspective what people are feeling when people come and talk about these therapies.
Yeah, I think when it comes to vitamins and alternative therapies, one, I didn't realize how vast the landscape was before starting this podcast. And then going on TikTok and going on Instagram and seeing how much was really out there, because we in the academic sphere just don't see it that much. And what we will get is patients will come in with a medicine list that has supplements, and so that's the most common circumstance is the supplements. And when we see a patient who's on a lot of supplements, St. John's Wort, vitamin D, whatever, I guess, yeah, vitamin D is one we frequently prescribe, so maybe that's not a great option. But all this crazy stuff like multivitamin, but other things that they think might help treat their cancer. We usually, and I'll say this is probably 80+% of practices, will approach it with a risks benefits thing, a risks harms thing rather. So maybe it won't help, and most of the time we don't believe it does. But is it going to hurt you? And if it's not going to hurt you, I don't care. Like do whatever you want. I'm your advocate. So there's a lot of things you can do, and I'm not, I'm going to support your autonomy as long as I don't think it's providing harm. In which case, my advocating for you is recommending you don't do it. That's my job. Now, there are circumstances where people will try to do therapies that are against the recommendation of an oncology team. And these may be like frequently traveling to a different country to get a medicine that's not approved in the US. And a lot of times it's not approved because either it doesn't work or it's dramatically unsafe. I'll
Mm-hmm.
give you an example. There was a patient who I cared for at a different institution who had a tumor that had gotten to the brain, and then they went to a different uh, country and got an injection of a solution into the spine, into the cerebral spinal fluid that bathes the brain. And it wasn't done very well. And it was, a therapy we wouldn't expect to work, but it was one of these all natural therapies.
Mm-hmm.
It was an extract of a plant. So they ground down this plant. And not that I'm against the principle of a plant working. Most chemotherapies, or many chemotherapies, were from plants. Like, those things do work, but it has to be the right plant and you have to know what you're doing. And this was not the right plant and they didn't know what they were doing. So this individual got fungus in their brain and died. So they came
Wow.
back to us because instead of seeking traditional care, they got something really dangerous.
Mm.
And then, it cost them their life. And that's not, so we see situations like that. We also see situations where someone will be recommended to get a certain therapy, and then they'll try a medicine that doesn't have evidence that it works, and they'll go from a curable stage to an incurable stage. And now they're going to die from a cancer they weren't originally going to die from.
Mm-hmm.
And that's really hard as a provider to watch. Like, it's really hard. And as a patient, you're allowed to do that. You're allowed to make decisions I don't agree with, but it doesn't make it easy for me as the person who's supposed to advocate for you. And we work really hard to get here. It's competitive to get here. Not an easy path. There's a lot of sacrifices so we can have the opportunity to help people. And watching them do things that hurt them is really hard to do.
Yeah.
So a lot of times the conflict that people see is from that. It's really hard for us to watch someone do something that we really think is going to hurt themselves. You can imagine a family member with a mental illness or something in a certain, I'm just using that as an analogous example of someone who is at risk for self-harm. It's really, really hard to be in those situations and watch someone do something that can hurt themselves. And I think watching a patient that's coming to you for help go down a path and you've seen it before, where it leads, but it's their first time. And that can be really hard.
Well, thank you for answering when I put you on the spot there. You
Yeah.
answered it well.
And the other harm is financial and time and hope.
Yeah. Yeah.
And those are real. And
Yeah.
this is true for a lot of the medicines that don't cause biologic harm to the body. One example might be, hyperbaric oxygen or high dose vitamin C, things like that don't really have strong evidence that they do anything to tumors.
Mhm.
But people will invest their hope in that, hoping that it does. People will invest their time. They'll pay a lot of money. And, it's all risks versus benefits. And, if people have the money and they have the time and they're willing to invest that hope, it's fine. But they have to be informed. Like, that's the thing, is you have to know there's not a lot of evidence here and it's going to cost you a lot. And if you're willing to take those risks, that and it gives you some sense of autonomy and some sense of control, sometimes that's worth it.
Mm-hmm.
As long as it's worth it.
Right.
And you're not riding on false hopes, which we see a lot in the medical oncology field. It's a lot of misinformation and false hopes.
All right, so let's switch gears and talk about something that I'm genuinely curious about, because I hear people talk about the Tumor Board all the time, and I've never been part of a Tumor Board. It's never been brought up in any of my care. I don't even know if we have a Tumor Board. It's this thing, a board of people that discuss patients' care collectively, that I'm like, why don't I have a Tumor Board? So I would love for you to dive into it a little bit so I can learn.
Yeah, so a tumor board is when a bunch of providers from different specialties come together and they discuss cases. Usually it's in a circumstance where the treatment you're going to do is not very straightforward. And we get everyone's perspectives. And I'll say largely tumor boards are based around curative intent treatments.
So maybe that's why I've never had one.
It's rare to get someone with metastatic disease in a tumor board.
Okay,
it can happen.
gotcha. Okay.
There are extenuating circumstances, but usually it's someone, and I'm speaking of our examples in lung cancer. It may be different for pancreatic cancer, it may be different for liver cancers, for example, but for lung cancer, usually what we're doing is we're sitting at in a conference room, and it's the medical oncology team, the surgical oncology team, the radiation oncology team. You'll have the radiologists there. You'll have the pathologists there. You'll have maybe someone who can do biopsies, like a pulmonologist. And we go through a series of cases and we say, this is a individual, we don't give names or usually personal information, but we'll say, 36-year-old lovely lady with HER2-driven metastatic lung cancer. And then we'll show the images, and usually it's around a question. And the question might be, this person has a type of cancer we think we might be able to cure, but we're going to need a combination of surgery, radiation, and medical therapies of some sorts. What should we do? And you might look and say, the tumor looks like it's in a place we really shouldn't be radiating, that's too close to the heart. Surgical oncology, do you think you would be able to operate on that? And they'll say, I don't know. Medical oncology, can you give something to reduce the tumor down? Say, okay, yeah, we can do that. So the plan might, and then the plan might evolve. Or, a lot of times it might be they got a biopsy and it wasn't conclusive. So we got another one. Pathology, can you review that biopsy? Okay, now it shows this. Oh, okay, what do we usually do with this new information together as a team? So it's a group of individuals that all work together to iron out a previously unanswered question that requires usually multiple disciplines together. For people who have a clear diagnosis, who have a clear plan, and that plan is an existing standard of care, like it's not necessary to always be at Tumor Board. So for many patients who are de novo metastatic, meaning they were diagnosed at stage 4, the standard of care is very clear, and the surgeon isn't going to be dictating that, and the radiation oncologist isn't going to be dictating that. There are nuances there, but by and large, that's the function of a tumor board, the groups that are involved, and then we'll coordinate whatever care needs to happen and try to get that done in a timely manner. This is a way that many patients who are new to a clinic, new to a facility, may actually get the input of multiple providers at once if it would be helpful for their care. So you may think like, oh, I have a referral to see this doctor. But if that doctor ends up putting your case up at Tumor Board, which for many people who have an ambiguous solution to their, plan question, they'll be presented at Tumor Boards frequently. But then they get the input of the whole team. I mean, they're getting multiple medical oncologists, they're getting pathology, radiology, everyone's there together. So you may be seeing that one provider, and that one provider may be dictating that care to you and telling you what everyone decided, but you're frequently getting the input of many, many team members. And, these kinds of conversations happen outside of Tumor Board too. It's not like that's the only place where interdisciplinary care, meaning a medical oncologist, a surgical oncologist, radiation, radiology, pathology, we talk a lot. But Tumor Board is usually like a weekly meeting where this happens at a consistent basis.
All right. Well, I learned something new. Appreciate it.
Yeah. I mean, it's a good system. I'm happy we've adopted it. I don't think this didn't used to always be a thing. But it does help iron out plans for people who are who are not super clear what the best thing to do is. And at least then everyone comes together and everyone's unified, and it's not the surgeon dictating to the medical oncology provider what to do, or me saying, hey, I already shrunk this tumor down, I need you to go operate. Now their hand is forced and they're like, this wasn't a safe operation, you shouldn't have done that. We all iron everything out in the beginning, and it makes things much, much smoother, and it's better care for the patient.
Awesome. All right, well, I'm going to switch gears again on you. We're going to talk about clinical trials a little bit. I know you touched on it a little bit, but I'm curious how involved medical oncologists are with clinical trials. Like when someone goes on a clinical trial, is there a medical oncologist that is running that trial?
Yeah, when people think of clinical trials, most of the time they're thinking of things in the medical oncology world and my type of treatments, the therapies that go everywhere in the body. It's not always true. Sometimes surgical oncologists will run clinical trials or radiation oncologists might, but usually it's associated with the thing they do. Like their trial might be some surgical trial, or the radiation oncology trial might be trying different doses of radiation or different types of radiation, or maybe a therapy that may enhance the radiation. But most of the trials that happen are, like we mentioned in another episode, they're in the metastatic setting, which is our world really as medical oncologists. And people think of their care teams as being predominantly the interaction that they see them in. Like, I'm a medical oncologist. Someone walks into my office, they see me, we discuss systemic therapy that goes everywhere, side effects, risks, how long the treatment's going to go for, things like that. But most of my time is not spent in clinic. And that's true for many providers, where still a good portion of their time is spent doing research or setting up trials, looking at trials, interpreting trials. So that arm of our work is really important to us. And I think it's important to know if the provider you're seeing has kind of expertise in one of those areas. It's at least helpful to know. But trials are pretty pivotal in what we do. Everyone has access to standard of care, or at least they should in the US system. And at least if a certain institution may lack a medicine in standard of care, they have a system to get it somewhere, like that is by and large something they have access to. Trials are different. Trials are a medical team comes together, they decide which trials they want to open at their institution, and institutions may choose differently. Some trials may be harder to implement the others, so only certain institutions will get them. And it may just be that, one institution already had a trial in that space. Someone was already had a trial for HER2 metastatic lung cancer. So, we don't pick up the next thing that comes out because we already have one.
Mm-hmm.
So it's important to, as a provider, to understand the landscape to the best of our ability, although it's hard. But trials are, for an academic center, really our bread and butter. Now, because we have a trial doesn't necessarily mean the trial's better. And this is a tough thing to swallow for a lot of people, because everyone assumes newer and more is better. And that's not always true. So a lot of times people will see community oncology providers, and there's a perception that care is always worse at a community oncologist rather than an academic oncologist. And I challenge that. Trials are another option. They're not always a better option. So, but they're a unique thing to academic oncology, such as a university of whatever. And as medical oncologists, they're pretty pivotal in what we do. And one of us is the lead on that. So if someone is, we would say, the principal investigator of a trial, it means they're in charge of that trial at that institution. So if there's a question about it, if we don't know if someone is eligible, that person's ultimately responsible. If there's a huge issue with the trial, that person's responsible. Similarly, that person's responsible for, understanding the data and how to incorporate the trial when it's completed.
I know that at some hospitals, they're obviously doing their own research, creating the drugs and doing their own kind of trials, but there's also like drug companies, right, that specifically want to trial their drugs at said institution. Do they specifically, like, how does that work? Do they just choose a medical oncologist at the institution and say, hey, do you want to run this trial for us? Or like, what does that look like?
Usually when a drug or some sort of therapy enters trials, it's coming from a pharmaceutical company.
Okay.
It's really rare that an individual institution develops something and they themselves put it in.
Okay.
Now
okay.
They can develop something and get bought by a pharma company. That happens. And because trials are very expensive, and usually they need to occur over multiple different institutions in order to make sure that your results are generalizable to everybody.
Mm-hmm.
But so that's kind of how trials initiate. And then the second half of your question.
Does the drug company kind of just
Oh,
pick
right.
a doctor, or like how does that work?
No, they may reach out to a group. For
Hmm.
example, if it's a new drug that's designed to treat colon cancer, they might reach out to the department head of some institution and say, "Hey, we have this new medicine. Here are the details. Would your group be interested? We'd love to tell you more." Sometimes there are individuals in the community that have a really clear expertise,
Hmm.
and they might reach out to those individuals specifically. But usually it's kind of a department choice, and then the you know the departments will frequently review trials together.
Mm.
And this has been true everywhere I've been, where this is the aim of the trial, this is the compound, here's the comparator arm. We go through all the specific details, and this is the group of medical oncologists coming together and make a determination, okay, based on what we're seeing here, how promising it looks, does it look toxic? And then what's everything else in the landscape? Are we waiting for something better that we're, thinking is going to happen soon, or do we already have something in the space? And then we'd have two trials in the same area, and we wouldn't be able to get
Mm.
enough people on them to actually interpret them. That's important. So there's a lot of considerations that go into it, uh, including who ends up championing that trial. Sometimes someone is an obvious choice, but their plate is really full. They're doing a lot of stuff. They don't have time to champion that trial, so it might go to
Gotcha.
someone else.
And this might be a controversial question, but I hear it a lot in the underground patient world. Is that sometimes people feel that their medical oncologist might be pushing a trial over a standard of care therapy to potentially just fulfill a number count
Yeah,
in the trial. I hear it a lot.
yeah,
And so I'm curious if you can talk a little bit about that in terms of, is there a pressure being an institution and getting a so-called body count in a trial, or is it a perceived falsehood that patients have kind of made up?
no, it's a good question, and it is a controversial question. You're really putting my feet to the fire there. So I'll say, academic institutions, if you open up trials, there is an expectation that you put people on those trials. There is, I guess I'll call it a bias. So I think the perception you're feeling is probably true. Now, we as providers have to do the best thing that we can do for the patient, and many times it's not putting them on that trial. So people may not be good trial candidates, but we still got a trial there thinking it was a good idea, and we made that call and our name's on it. And there are incentives like these kinds of, whether it's, you know, the they're not always financial incentives, but if I'm the head of a trial and I want it to be a good trial and I think it works well, and I'm biased because I chose it.
Hmm.
So there are biases in there for sure.
Yeah. Yeah.
And you may find that the person who's running a trial is more likely to put someone on that than the person who isn't running it.
Right.
That's just the
That's fair.
bias.
Yeah.
And even if, I mean, I don't think people are twisting their mustaches wondering how to use patients for their own personal gain. Like,
Yeah.
that's not it.
Yeah.
It's more that they have already invested in it, and it's what they thought was a good idea.
Hmm.
And they may be invested in seeing it through and trying to offer what they think is the best for their patients through the trial. Whereas if someone else didn't go through that process of screening the trial and talking to the drug companies and having meetings with them and making sure it implemented correctly and all this kind of stuff, if you didn't go through all that, you may have less of a bias.
Hmm.
Now, that being said, I know plenty of doctors who have opened up their trials and then they see some early signs that it doesn't look good, or like patients are progressing quickly, or there's toxicity, and maybe there's some concerns for early safety data. That ends up leading to the alternative bias, which we shouldn't really be doing because you don't know the answers to those questions until the trial is really read by the scientific group that's going to interpret it. Because sometimes maybe, there's 20 patients in a trial, I see three, and those are the three that just did poorly. that can happen. But so we want to wait until the data is out. But I would say there probably is a subjective pressure to put patients on trials, not only because the person may be running the trial, but also because that's frequently, for those of us in academic institutions, that's the best thing we have in our toolkit. So yeah, I think there probably is a push for that, but it may not be as nefarious as it sounds.
Okay, that's good to know.
Yeah, I
It's
mean,
just
but you're also asking someone who's biased. So
yeah.
um, yeah, it's asking a dentist, do you think it's worth brushing my teeth?
That's
I
fair. That's fair. So let's get into some more patient communication stuff because I think patients who are always curious about some of these areas in terms of how medical oncologists feel about different situations and scenarios and like um, what are some of the hardest conversations as a medical oncologist you think are had?
I would say the most challenging conversations that I have with a given patient is when it's time to end therapy,
Mm,
and patients don't always see that coming.
mm-hmm,
The goal of the therapies we give, as I've said before, is to provide the longest amount of time with the highest quality of life,
mm-hmm,
not to provide the most therapy possible.
right.
And sometimes that may mean redefining what fighting looks like
Mm-hmm,
and what the goals are. But we like to have this perception that it's always the patient's choice, and it's not. Sometimes when we just run out of reasonable therapies to give, the patient may want more things, and we just can't do it. It's not safe. It goes against our moral code, and that's really hard. You get second opinions for people who come across the country and they're hoping you have this thing that's going to reverse cancer growth, and you just don't have it. It doesn't exist, and you have to tell them that they really are at the end of the treatment road,
mm,
and now it's time to just focus on symptoms. And that conversation doesn't happen when the patient's ready. It happens when
right.
the tumor's growing,
Yeah.
and that's really hard because we want to be the people who are able to offer hope, and a lot of times that's our bias. Physicians very frequently overestimate the duration of time their patients are going to live,
Mm-hmm,
and they overestimate the amount of time therapies are going to work because we are biased toward hope. Um, but sometimes when patients are just too sick, or there's just no more treatments left, and the patients, it's really hard to tell someone that.
mm-hmm,
Um, that's definitely the hardest part, I think. And the hope is that it doesn't happen overnight. The hope is that that conversation is part of a long conversation around expectation setting
mm-hmm.
and knowing, steps 1 through 10 of the game plan, and knowing that that last step is at some point these are going to stop working, and I'll let you know when it does. Um, but being at academic centers, frequently we get people for second opinions looking for the Hail Mary,
Mm-hmm.
and we can't always provide that, and that's tough.
Do you have patients that you still think about in terms of patients that are no longer here that you treated and because I never think about in the mind of a medical oncologist like how much of an impact that might be.
For sure, yeah.
Yeah.
I think everyone who's gone through oncology training and is seeing patients, it's pretty much across every spectrum. Whether you have patients with a given tumor type where the tumor is really aggressive and patients don't live very long, that's really hard.
Mm-hmm.
But even if you have a patient population as an oncologist that do really well, and 95% plus are cured, 90% are cured, what happened to the other 10%? You still have to, and those are individuals to us.
Mm-hmm.
We read about them in statistics, but we see them.
Yeah.
And uh and it's interesting, we have a general sense when someone comes to see us the first time, if they're just beginning their care or if they're coming as a second opinion. we have a sense for how things are going to go.
Mm-hmm.
So we temper our own emotional
Mm-hmm.
expectations and involvement appropriately,
Mm-hmm.
or at least that we need to do that because we have to stay effective for everyone else. You think the biggest thing you want for your medical oncologist is someone who has empathy, and you want that, and that's a good trait usually, but you can't be so heavily grieving that you can't care for these other people that need your help.
Mm-hmm.
So it's a challenging balance, I would say, the emotional compensation of dealing with tragedy all the time. Because it's true, every patient dies at some time of something.
Mm-hmm.
That's the natural course of human life. But I think the times where it's probably most challenging are when you relate more to that person or when it's just really unexpected.
Yeah.
And a lot of times, as medical oncologists, what we do is not benign. You and I have had many episodes where we talk about chemo, we talk about antibody drug conjugates, we talk about things that are toxic, and rarely those things really do knock people down.
Mm-hmm.
And I'll say the trials that do all these therapies exclude people that are really sick.
Right.
So when someone comes to us and they're really sick, we have a chance of doing more damage with the therapy we give. And you have to weigh, okay, was that the right call if we didn't or if we did? If I gave them something and it killed them,
Mm-hmm.
was that the right call? Probably not. If I
Mm-hmm.
didn't give them something that could have helped them and then they died, I don't know. So there's a lot of ambiguity there. And those decisions stick with you.
Oh,
But
I'm sure.
yeah, I think the only solace is that cancer's so terrible
Mm-hmm.
that it's just, you have to acknowledge that this is a game that is not winnable in the traditional sense that every decision is going to be the best decision and you don't have the crystal ball that tells you what the right call was. And there are enough situations where there's just no good answer.
Yeah.
And that's where second opinions are actually helpful. As an oncologist, when a patient has a second opinion from something we recommend or they're coming back to us, it's a testament to how complicated the disease is and how challenging this field is. Having the other opinion of someone else can be really helpful for us emotionally.
Yeah, the nurses in my infusion room, I had a really open dialogue with a handful of them. I'm just like, how do you cope with seeing all of these people going through cancer? And they especially don't even get closure necessarily because people just stop going to infusions and they never know what happened to that person unless they look them up. And a handful of them told me like they just can't get attached to these people because otherwise it will be heartbreaking every single day. They have to be slightly removed from it. But they said there's always that one patient that they do get attached to, and it's really really tough when things don't necessarily go to plan or go right in the end, and it's really hard for them, and they have no real way to cope with it.
Yeah, and I'll say as a medical oncology provider, as the person who's seeing the patient probably for the longest amount of time,
Mm-hmm.
it's possible to not get terribly attached.
Mm-hmm.
You can be really methodical and treat the case. And for those who are listening, there are many people who have oncologists that they're going to think are like this, and they may come off as cold and they may come off as distant. But sometimes it's kind of what you need to do to deliver effective care.
Mm-hmm.
Because being really empathic and really connecting with your patient comes with emotional vulnerabilities that may not let you provide care to people who really need it.
Mm-hmm.
Now, I'm, as you know, a little more touchy-feely guy, and so I am a little more emotionally connected, I would say. But it's tough. It's tough to not be able to just have your patient not show up one day and not know what happened. That we know what happened.
Yeah.
We're told many times oncologists will be invited to the funerals of their patients.
Mm-hmm.
And one of the nice things about working in research is I get to use that suffering for something that I think is better.
Mm-hmm.
Um, so I have found a way to let the pain that I feel when someone I know dies, I've figured out a way to leverage that towards something that I think is positive, and it keeps me going. That's what, rather than dwelling on it, I have some conduit to just get up and keep at it. But not everyone has that I would go so far as to call it a coping mechanism. Not everyone has that kind of coping mechanism, the privilege of that kind of coping mechanism, really. They just have to go see the next patient.
Yeah. But I would also think that choosing the field of medical oncology, you kind of know what you're going into, right?
Yeah, it's self-selecting, and that's a difference between surgical oncology, radiation, and medical oncology. Is the interpersonal dynamic between yourself and the patient. If I were to distill it, surgical oncologists and radiation oncologists have a technical skill set. That's why you're hiring them, is they're there to get the best margins, to give you the best chance of cure or the most alleviation of your pain. Medical oncologists frequently they have a similar armamentarium to each other. So, there are differences, but it may not be so drastic as someone who only does lung cancer surgeries and that's all they do versus someone who's a general surgeon.
Right.
Like, those differences are going to be vast in technical skill. But a general oncologist and very specialized thoracic oncologist may reach for the same thing and it will have the same effect.
Yeah.
So there is a lot of psychosocial dynamics, and we went into internal medicine, which was a field where we think about how the body copes with illness, and we try to, most of us are trying to train to treat the whole person. And in oncology, it's a tough field for that. But we have supportive teams too. Many of us will see therapists, and many of us will rely on each other to talk about these challenging cases. So we're not alone in that. But I think and we're not always the best at allowing ourselves to feel vulnerable in those ways. And that's not something you're going to see at conferences. So it's a tough field, and I wouldn't change anything. I like that, but medical oncology is probably unique in that way.
Well, thank you for doing what you do.
Oh, well, thank you for asking me all these hard questions.
Absolutely.
Getting this out. But yeah, hopefully, for folks still listening to the end here, we've answered your question, at least to the role of medical oncology, some of the nuances, what we do. We didn't get too much into, the path in tremendous detail, but I think we reasonable sense how we're different and who you might see. Any other things, Samantha, or do you think we about covered it?
I think we about covered it. We can always do another one.
We can. Yeah, we can. Okay. Well, hey, thanks everyone for joining. This is, again, Cracking Cancer. And if you like this episode, you can like and subscribe and visit crackingcancer.org for more information. And we will see you next time. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.